Good morning and welcome to the Royal College of General Practitioners. This morning our guest is Professor Steve Fields. Steve Fields is the chairman of the Royal College of General Practitioners, and the fact that we have here a chairman, not a president, perhaps illustrates to us the collaborative and cooperative nature of general practice, not just collaboration with the profession itself, but also of course with multiple professionals and with patients. Steve, thank you very much for your time this morning.
Pleasure.
I always start this series by asking the same question, which is, how come you became a doctor? What led you into medicine as a career?
Well, I've always wanted to be a GP actually, because that was the role that I saw doctors doing. But I grew up in a very deprived part of central Midlands, the Black Country, and we had a bit of a rough time when I was at school and growing up, and I looked around when you had to sort of decide what you wanted to do or be, so around about 11 or 12, and I saw our local GP being someone people looked up to. I thought he was doing good for the community, and people spoke very positively about him. And so when you were looking at a career at 11 or 12, I wanted something which I could give back to the people that I was living with. I look back on how I grew up, and even at 12 I wanted to do something about health, about trying to provide health like my local GP for whoever people were, whether they were poor or rich. And at that point that was how I sort of framed things. And so it was just natural really to head at the age of 12 to becoming a GP, and then subsequently 10 years later that started to happen. Well, I was the first one from the family to go past 13 at school. So going into 14 and 15 was a new venture for the family, which was great, and had lots of support from then. So I applied to Birmingham Medical School because I grew up in the Black Country. We'd moved for all sorts of reasons to Manchester, and I wanted to go back with a view to being a GP where I grew up until the age of sort of 10, 11. So I wanted to give something back to that community in the Black Country. That's what I really wanted to do. So I went into medicine focused on coming out at the end as a GP, and I didn't really move away from that. I was very interested in public health, very interested in dealing with the patient in front of me, and becoming a specialist didn't really figure at all. I enjoyed all of the hospital posts I did. I made my own GP scheme up, and the feedback was really good. I had two fantastic mentors, at least two, but two as a houseman, John Black, who's now President of the College of Surgeons, and Richard Taylor, who became an independent MP, and they had different perspectives on life. Both were specialists, but even though I really enjoyed working for them, I still wanted to be a GP, and then made my own programme up, and then went into general practice as soon as I could.
So it would appear that you undertook a general practice training programme at a time when there weren't very many of them around.
Well, there were training programmes in the West Midlands going back into the late 60s, but there were very few programmes. It became compulsory in around about 1980, but to do general practice training. But in the West Midlands, what we found was that 8 of the top 10, I think, in medical school went into general practice. When I applied for a training programme, I didn't think I would get on the training programme, so because there were sons and daughters, mainly sons of local GPs, and there were people who were better than me academically. So I thought, as a long stop, I'd make my own programme up and still apply for the training programme. And I didn't get on the training programme. 2 people did out of the 100 and something that applied, and they actually deservedly got on the programme. So I did some anaesthesia, actually, some paediatrics, obstetrics. I went to Australia for a while, and I had a really good time, and I spent a little bit longer than most doing that, but still focused on what do I need in order to acquire the skills to become a GP later.
And Steve, what do you think are the main challenges for general practice now?
Well, as we sit here, we have a new government, and there's going to be increasing pressure on GPs to deliver from a commissioning of care point of view. I'm sure it's the right policy. It's actually an extension of what happened with the Labour government, which failed, world-class commissioning failed, largely because the managers in many PCTs blocked the doctors making decisions. If we go back a few years before that, then there were early forays into this with fund holding. So I think the twin tension will be, how do GPs get involved in actively making population-based commissioning work whilst carrying on to deliver and improve the quality of care they provide in primary care. So that twin track will cause some difficulties unless we grow the leaders both for clinical delivery and for commissioning at the same time, and really take the profession with us. So that's going to be the big problem. I think we've had a number of years, probably since Roy Griffiths professionalised managers in the early 80s, where clinicians have been sidelined, particularly in primary care. I think people have hid behind the fact that we're independent contractors and therefore unmanageable, in their words, and haven't secured the support of GPs. So I think the real pressure for GPs and for the system as a whole is, how do we regain the confidence of GPs? How do we make sure managers support the clinicians rather than block some of the changes that need to happen? And then how do we address the variation in care of provision in primary care? And I think all that can be done much better if GPs lead the system. But we need support. The real danger is being set up to fail in some areas, because that's the history. It's easier to blame the clinicians. And actually, I think what we need to do is work closely with management to make it succeed. Because I think the areas where commissioning and provision work well, Kaiser, veterans, other areas like that, where clinicians are leading, actually we can have a better system here as well.
And Steve, you're coming to the end now of your tenure as chairman of the Royal College of General Practitioners. What about the future? What are your plans now?
Well, who knows? I mean, absolutely love seeing patients. I couldn't do it every day of the week now. I think I can offer more by going in for the one day that I do. I think patients can have all of my attention for that day. And I work within an academic, very supporting environment, so I want to carry on seeing patients. I want to carry on doing the work with Harvard on leadership and training there. And then the big question is what I do for the rest of the time. I have a return ticket back to the West Midlands to be postgraduate dean, but there again I've got more involved in policy. So I hope that I can use what skills I've gained and what knowledge I've gained to try and address issues like inequalities, deprivation, clinical leadership, and try to improve the system we have here. So it's a difficult time at the moment because I'm not exactly sure what's going to happen, but you know.
I'm sure you'll grasp the opportunities like you did before.
Who knows? It's usually by accident, so something will happen possibly by accident. You never know.
Steve, you clearly came from a background that it was not traditional, not a middle-class medical family. How do you think we might improve the accessibility of medicine to other social and cultural groups?
I mean, that's a very, very good question. I've just spent a week away talking about these issues with Canadian colleagues, because obviously they have issues in the remote and rural areas of Canada, but and how do you attract people into inner cities? So we were throwing these ideas around. In England, we mainly have a school to university entrance. There are some graduate programs, but mainly school to university. And I think that is a block for many, particularly white male doctors to be. We don't seem to be having enough going into medicine, particularly from more deprived areas. We haven't improved over the years. In fact, the percentages, I believe, have gone backwards. And that might be a bit of role modelling. It might be because it takes us a while to grow up and understand what's happening. And so graduate entry schools provide an answer, I think, so people can do a degree and then have access later. I think we've also got a real role modelling problem. Black girls don't tend to go towards medicine either. And so perhaps what we need to do is look at education from primary school, junior school, and we know the work of Chris McManus in London seems to indicate people make decisions around about the age of 12, in which GCSEs they go to. So I think it's about role modelling career opportunities back right into primary school, all the way through, and then more graduate entry placements. I would increase the numbers dramatically and redress the balance with school into medicine. And then I would open up the graduate entry schools to people who've done arts subjects as well, because people mature and change and look at the world in different ways. And one of the ways they do this abroad is because they do an early degree before they choose, and so they are really only choosing towards the end of school early degree. I think that's one way. I think we should also seriously consider some schools where we have a pluripotential start, where people might do a health first year foundation and then move off into physio or into nursing or into radiography or into medicine as well. I think that might help some people decide which of their health-based careers they're going to, because it's not just certain aspects, certain parts of the community, such as the more deprived areas, we're missing. And of course, if we get people in from the deprived areas, the economic effect on the family is tremendous. But it's also people who we have a more sharing, caring approach rather than interventional approach to medicine. We're missing those as well, and perhaps if we could look at those areas later, that might help us recruit a broader group of people.
Thank you very much.
All right.